This lecture is on endocrine drugs. We can't talk about the endocrine system or endocrine drugs without talking about the pituitary gland. When we talk about the anterior pituitary gland, we're talking about things like growth hormone and thyroid stimulating hormone and adrenocorticotropic hormone, gonadotropins. When we talk about the growth hormone, we look at drugs like protropin and humatrope, and those are for growth hormone deficiency. Growth hormone excess, we look at bromocriptine, octreotide. These are for growth hormone excess. Thyroid stimulating hormone, we use drugs like thyrotropin when we have deficiencies there. And then when we have problems with the adrenocorticotropic hormone, we give corticotropin. Corticotropin is either Acthar or ACTH. Stimulates the adrenal cortex to secrete cortisol. Its use is to diagnose adrenal gland disorders, so it's used in that diagnosis process. Also to treat adrenal gland insufficiency and then anti-inflammatory drugs. It can be used as an anti-inflammatory drug in the treatment of allergic response. When we look at the posterior pituitary, we look at things like the antidiuretic hormone. One of those is DDAVP or desmopressin. This one, we're suppressing urination. We're keeping more fluid on board. So you want to think about, if we're keeping more fluid on board, what kinds of things can happen? Well, hyponatremia can ensue. And that can be very dangerous. It can make a person very confused. And it can be very dangerous throughout the body. Electrolytes are very important. So if you have hyponatremia in a patient and they're getting DDAVP, we would want you to hold that medication and call the MD for that hyponatremia to get further guidance on that. The thyroid gland hormones include T4 and T3. So TSH is actually elevated in the person who has an underactive thyroid gland. It's part of the feedback mechanism where the body is trying to stimulate that thyroid, but the stimulation isn't working. However, the feedback system may still be working. So the feedback elevates that TSH, and you've got an elevated TSH when they have an underactive thyroid. For this, we give Synthroid. Synthroid, you'll notice, is given in micrograms. So, we can start 25 micrograms. We can have a patient on 100 micrograms. But they need to take this in the morning. We often give it at 6:30 in the morning. Couple of reasons. We want to give it before breakfast. And we want to stimulate that metabolism in the body before breakfast hits. It also helps the body use it correctly because it gets to that person at their right point in their circadian rhythm. And their circadian rhythm has many hormones involved daily going in cycles. And then another thing is if we give it at 06:30 rather than 7 o'clock, it doesn't fall on change of shift. And change of shift is actually a really dangerous time for medications because they have a higher risk of error. So 6:30 is when we designate as a good time for that. Some side effects that can happen because of Synthroid include nervousness, insomnia, weight loss, tremors, headache, nausea, vomiting, diarrhea, cramps, tachycardia, palpitations, hypertension, dysrhythmias, and angina. A thyroid crisis or a thyroid storm is a medical emergency. You might see a fever, nervousness, rapid pulse, insomnia, diarrhea, or hyperkalemia. So that is basically Synthroid in a nutshell. We also look at the parathyroid gland just a little bit. The parathyroid hormone regulates calcium levels in the blood. Parathyroid hormone agents treat hypoparathyroidism. Calcitrol is a vitamin D analog that promotes calcium absorption from the GI tract and secretion of calcium from the bone into the bloodstream. We really need to get into the idea of the adrenal glands because we end up giving lots and lots of patients corticosteroids, glucocorticoids, or steroids. One of them is prednisone. So prednisone is something that we use quite a bit to treat exacerbations, things like asthma exacerbations, ulcerative colitis exacerbations, COPD exacerbations, rheumatoid arthritis, eczema exacerbations, all sorts of things when they're exacerbated. We don't often give it long term. There are instances in transplant patients and things like that where we do. There is impaired healing. One of the side effects of taking a steroid is that wound healing will take a little bit longer. And it also will immunosuppress someone. So make sure they're taught to wash their hands and report a temperature. It's really a big deal if you're immunosuppressed and you have a temperature. You also want to tell patients not to take NSAIDs with these. This is a really bad thing to take NSAIDs with, and it increases your bleeding tendencies quite a bit synergistically. You also want to tell patients to avoid chocolate, coffee, sodas, because these have caffeine in them, and that is something that interferes with prednisone. The person probably will have more jitteriness. Also, people may have rapid weight gain, but weight gain where you're gaining 3 pounds a day or 5 pounds a week, this should be reported to the doctor because it could be fluid retention. Patients should not stop this abruptly, or they could succumb to some Addison's syndrome symptoms. The symptoms with that are abdominal pain, weakness, and weight loss. You want to take this at the same time every day, and prednisone can be quite harsh on the stomach, and it tastes horrible for kids. So definitely you probably want to take it with some food. So take it in the morning, or you're going to be up all night. And with kids, if they're getting the pre-loan, go ahead and give them an Oreo cookie afterwards because it tastes awful, and they'll get better compliance that way. Thank you.